After that, our next topic is the Bell palsy. That is also a very important topic because when you can see in this model also, when we are learning from the cranial neuromanual therapy, there we have learned about the all the cranial nerves, which plays a very major role either for the balance or for the eyes nerves, which are related to the eyes or nerve, the facial nerves, vagus nerve, accessory nerves, all the nerves with all the cranial nerves according to their manual therapy, how we have learned, that is a very different thing. But today, in the form of articular, myofascial, and neural, we are treating the Bell palsy as all these three component also, where we add components according to the positioning or according to the branch which is going to supply in that particular region. According to that, we treat our patient. So in this this side, you can also see that how they have shown the cervical spine and the brain also, cerebrum, pons, and the medulla oblongata. So all these things are very clearly in this or the muscle, the structure of the nasal cavity, or there is a mouth, that all the hypoglossal, glossopharyngeal. So these are, they have shown in a very beautiful way. We can see it. But now our role is for this, where we are going to more learn about the facial palsy. So because we know that whenever the patient, we see the patient of the Bell palsy, so it comes in our mind that either this is the upper motor neuron palsy or the lower motor neuron. So these things we should first clarify, which in our session sir has clearly mentioned that when we treat the Bell palsy, this is the lower motor neuron palsy. So in this, because in upper motor neuron palsy, the patient is having a weakness only below the eyes, they are having a weakness. But if there is a lower motor neuron palsy, so it means ipsilateral side, all the muscles get the weakness, or the contralateral side, which is coming from cortical. So the below the eye, that time the contralateral side, they get the weakness. So when we see our patient related to the Bell palsy, we see their symptoms, their eyes problem, they cannot open, they cannot close their eyelids. So this is the problem. The drooping of saliva, this is the problem. And their smile become, they cannot smile because one side there is a dropping of face also, and they can like they cannot full air in their mouth because of the weakness of the buccinator muscles. So this is the thing, we can see that how this is the ear. All around the ear, we know there are cranial nerve like the vagus nerve, vestibular nerve. These are nerve, or the facial nerve and trigeminal nerve. They all are coming all in and around the ear. So it means when we are going to treat the facial nerve, it is important to see that either the nerves, the nerves which are also all around the ear, that is also in the part of are also in the compressed form, or there is only the facial nerve. So we see that because we know there behind the ear itself, there is a stylomastoid foramen from where this nerve coming, and this is the, you can see the parotid gland, this is, and after that the all the branches of the facial nerve is coming out, and these branches are going, one and going in the temporal, orbicularis. This is the orbicularis oculi, the eyes muscle, suppressor, and the all the muscles all around. And then the one is in the zygomatic branch, where is the major and minor zygomatic. Then for buccinator or orbicularis oris for the mouth, and one is going in the this is mandible, and in the cervical in the platysma. This is going in the cervical branch. So whenever we see and the patient, so we see their activity. There is a, because of they are having a lacrimal glands also affected. So the tears problem, saliva problem. So how we can move it? So in this Bell palsy, what we do normally as a treatment according to the cranial neuromanual therapy, what we do, we add our component according to that. Like we know that the upper part, there is a frontalis, occipitofrontalis muscles, and there is a supply of the facial nerve in the all around the eyes. So what we do, we add the cervical, upper cervical flexion and the lower cervical flexion. That time, we see that the symptoms of the eye, when we are going to treat the eye, that we see in our slides presentation also how we are going to treat. So that component we add for the upper area, the upper cervical flexion and lower cervical flexion. But when we come towards the face zygomatic and the buccinator muscles, there with the lower cervical flexion, upper cervical flexion, we add the rotation because these are in the cheeks part or near the cheeks or mouth. So that is the rotation plays a major role, loading or offloading of the facial nerve. But when we go into the towards the lower part, so there the cervical flexion, lower cervical flexion, that time we do the lateral flexion because this is the lower area. So there the lateral flexion will load and offload the nerve, and according to that we give the actively the tensioner, or passively we add the sliders for the facial nerve or their branches according to these components. It means I have added articular with the cervical spine. I have released the muscle where I have found that there is a trigger point or there is a swelling also because of the fluid retention in the face, because the movement is not going on by these muscles. So there is a fluid retention. So there is a swelling. So we have to drainage that swelling also. So for that, the swelling, or we can see that either there is a trigger point is there in the masseter or in the zygomatic bone, so that there we can release the myofascial. We can use the soft tool of ISTM also for releasing separation the muscles layer also. So this is the way the myofascial and the neural we offload opposite side, or with the same side we add the neural component also the facial nerve. When we add the contral side, we load that because as we know that there is a ganglia. So whenever we turn, so it will give the loading of the nerve. At the same side it will offload. So whenever we want to treat the patient as a neural component, we add the rotations or lateral flexion or with the flexion movement. So the articular myofascial neural, that time we can train the patient whatever the activity. If we want to give the activity for the we want to just give the lifting of these oris muscles, so that time actively or passively we can train the patient. Or for the eyes also, we can give the PNF pattern irradiation from normal side to another side, so that that eyes muscle can also be start working. So this is the way we treat our patient, and not only any musculoskeletal condition. It means we can treat the cranial nerve also as a articular myofascial and neural also, that we will see in our slide presentation. So in this slide, in this model, you can see that how beautifully all the nerves are passing through all the branches in the buccinator, in the masseter, in the zygomatic, in the orbicularis oculi, and the orbicularis oris, nasalis, because all these muscles plays a very major role when the patient is having a Bell palsy. So we have to train all these activity either for the like balloon, or like we can give them a candle so that they can blow that. So these are the thing, activity for these muscles is very important. So by this, we can see it in this model also. So how it is important to treat this part for the Bell palsy. Yes, sir.